Okay, good afternoon, everyone. I'm
Good
Alethea
afternoon.
Carr, one of the co-leads for SimQuick, and we're glad to welcome you to Tools for the Field, addressing maternal mental health. We have a really rich agenda today, and looking forward to hearing from our presenters. Let's go to our next slide. We included this comic because I think it's very appropriate for the topic of our presentation. May is Maternal Mental Health Awareness Month. And as you read through the mom's thoughts, even though she says she's fine, it may be a familiar scenario to many of you that are on the call this afternoon. Our agenda is laid out for you. As I said, I'm one of the co-leads for SimQuick. I will be with you for just a few minutes to give you a brief highlight of SimQuick and what we're all about. And then you'll hear from our presenters that will be talking about two programs and services that are available in this area to support women, maternal women in the area of mental health. As we listen to the presenters, please feel free to include any questions or comments that you have in the chat. We will work to address those as we conduct the session this afternoon. And if by chance we don't have a chance to answer all of the questions, we will certainly get back in touch with everyone with responses for any questions that you do have. Here are a couple of questions we want you to keep in mind as you listen to the information that's shared today. What will you take away from this webinar, and how will you use it? I think that's really important because mental health is one of those areas that is very important for pregnant women and postpartum women, and any woman really, considering the burden that we often carry in our life, as well as considering the last year or so we've been in this pandemic situation. So please listen to the information and think about how you'll be able to use it in your area. Next slide, Devin. SimQuick is stands for Southeast Michigan Regional Perinatal Quality Improvement Collaborative, and is one of the collaborations that was established by the state health department to address maternal and infant health. We have more than 60 organizations that are part of SimQuick. We represent Region 10, which includes Wayne, Oakland, and Macomb counties. And in terms of the state's births, we are about 40% of all of the births in Michigan and about 60% of the Black births in Michigan. So really have a significant contribution to the health and well-being of families. One of our main goals is to narrow the disparity between Black and white births that exist in our region, with a focus on, as I said, maternal and infant health, including infant mortality. So with that, I think, well, I will also mention we started in 2015. So we've been around now for over 6 years. And if you're not familiar with SimQuick, we have meetings quarterly. Please, since we've been in this virtual environment, we have virtual meetings. Please feel free to join our meetings. We'll make sure you get the information about the next scheduled meeting, which is later in June. And I think I'll turn it over to Lisa at this point.
Okay, well, good afternoon, everyone. My name is Lisa Braddix, and I'm one of the co-leads for SimQuick. So thank you for giving that overview for everyone, Alethea, just in case we have some new people. So I'm gonna start us off with some important data, particularly data related to mental health and pregnant women or postpartum women here in Southeast Michigan. So all of the data that I'm going to present comes from the Michigan PRAMS, which stands for Pregnancy Risk Assessment Monitoring System, for just in case you all are not familiar. And you can, if you want to take a deeper dive into all of the PRAMS surveys and reports, you can just Google Michigan PRAMS or go to the Michigan Department of Health and Human Services website, and all of the information is there. So PRAMS is a survey or a monitoring system that surveys pregnant and postpartum women and asks them about the different experiences that they've had during pregnancy, and one of them is life stressors. And so the chart that you have here comes from a special PRAMS report that is focused specifically on women, pregnant and postpartum women in Detroit and Outer Wayne County. And this is when they were asked about the life stressors. So for example, if they had to suddenly move, or if they had a loved one who was sick and had to go into the hospital, a number of different things related to stressors in life. You can see the difference broken down by geography, and a greater percentage of women, say in Detroit, for example, compared to Wayne County, and then compared also to the rest of Michigan, reported having 3 to 5 or 6 or more life stressors going on within that 12-month period prior to them having their babies. So there's a lot of stressful situations in which pregnant women are experiencing their pregnancies, as well as birthing in postpartum periods. Next slide, please. So these are, of course, things to keep in mind when we're talking about contributions to mental health conditions. Adverse childhood experiences. Many of us know that over the last several years, people in the mental health field, people in public health and medicine have been learning more and more about the effects of adverse childhood experiences, negative things that have happened during childhood, and their contributions to health, physical and mental health throughout the life course, and even how they contribute to the likelihood of risky health behaviors or even shortened lifespans. And so this, of course, is a chart that outlines that. You'll hear probably more about that from our presenters that are going to be following me. But it's important to note that in the PRAMS report, close to half of Michigan mothers reported that they experienced at least one adverse childhood experience. And then almost 7% reported having 4 or more of these childhood experiences, which lends to some of those riskier health behaviors like smoking. And a number of mothers reported that they were indeed smoking. There's a higher likelihood of engaging in that risky behavior even during late pregnancy. So also something to keep in mind. Next slide, Devin. Tobacco and marijuana use. 14.5% of mothers reported postpartum, this is 3 months during postpartum, that they were smoking cigarettes, and then 7.5% mentioned smoking or using marijuana. And so this is something that we've got to be mindful of. There's some anecdotal data in our partners that do home visiting that they've shared with us, that a growing number of instances they're having to counsel pregnant women about marijuana use during pregnancy, and especially, you know, during the time now that we've got the legal use of recreational marijuana here in Michigan. We've got to be extremely mindful of that, and why women are choosing to engage in tobacco, marijuana, or even alcohol or other substances during or postpartum pregnancy, oftentimes maybe to self-medicate, oftentimes maybe to just cope with some stressful situations. Only just over 60% of women reported being asked about tobacco use during their postpartum checkups. And then, of course, about alcohol. PRAMS currently does not have data on alcohol use during pregnancy, but I believe, and I have on good authority, that that is a plan for the future, the near future. But just over half of doctors asked about alcohol use during that postpartum checkup. So these are things that we've got to kind of zero in on and be mindful of when we're talking about maternal mental health. Next slide. Postpartum depression. So 2018 data for PRAMS indicated that about 16% of mothers reported having significant postpartum depression. So another point of note there. Next slide, Devin. So finally, for those who may not know, the state of Michigan Department of Health and Human Services very carefully developed a improvement plan focused on the years 2020 through 2023, outlines some goals and objectives that we want to meet as a state in terms of improving maternal and infant health outcomes. And one of the priority areas focuses in on mental, emotional, behavioral health, and well-being. And one of the things that is of importance in that overview, and I encourage you all to get a copy of this. It is available online through the MDHHS website if you've not seen it before. But there is a focus in this priority on screening for mental and behavioral health conditions, including postpartum depression, which we just touched on, and substance use disorder. So again, I encourage everyone to take a look at this report and see the various areas in which your organization can support the progress towards the goals that are outlined for 2020 and through 2023. So with that, I will pass it over to our first presenter, Dr. Maria Muzik, who's going to present about the MC3 perinatal program, one of the tools for the field.
Hello, everyone. Thank you for having me. It's wonderful to be here. And oh, I see you have my slides. Excellent. So thank you so much for uploading the slides. And as said, my name is Maria Muzik. I'm associate professor in psychiatry and OBGYN here at Michigan Medicine, and work with many organizations statewide to promote really maternal mental health. And I'm also the medical director of this MC3 perinatal program that I want to introduce to you. So next slide. To set the stage, following really nicely to what Lisa was just presenting, maternal mental health issues like depression, anxiety, actually trauma, PTSD, substance use are not uncommon. We have really good data on anxiety, depression, 1 in 7 women, but we also know that between 5 and 10% have substance use issues. We know that PTSD is 7% of moms have PTSD in pregnancy, postpartum. So there is a lot of mental health issue, and it really impacts not only the mom, it impacts the whole family, the extended family, the immediate family, the unborn child, and other children in the home. And what is really a big issue is that only a fraction of women receive the care that they deserve. 15% are really, this is kind of summarizing national data, is really a more optimistic view. And in fact, in some reports, only 5% of women get the appropriate treatment and are treated to remission. So in my clinical experience and my research experience over the last 20-some years, I think that there are several contributing factors, but some that really are possible to be tackled by this MC3 program: screening, access, and know-how. Screening, meaning universal screening, more or less, and not having it be random whether somebody uses screening tools or not, and is he asking or not. Actually, using standardized screening should be standard, because otherwise doctors often are complicit and do not ask, as we just heard from the PREMS data. Number 2, access, meaning that everyone should have access to immediate treatment options, and that there are many barriers, and we are trying to tackling those. And then know-how, both in terms of psychotherapeutic know-how and having enough workforce, but also in terms of the providers, the frontliners, having the know-how how to safely and responsibly treat women in this time period. So with that said, next slide, please. MC3 is trying to tackle this issue, both on the provider side, provider-facing options, as well as mom-facing options. So provider-facing options is really tackling the know-how. To know how to those who are the frontliners mostly working with moms in pregnancy and postpartum in the medical office. So these are the OBs, family docs, nurses, nurse midwives, physician assistants. It's not the shrink. It's not the psychiatrists. We don't have enough psychiatrists or even psychotherapists to go around. The bulk of the treatment first responders who are working with women in the perinatal time, like pregnancy, postpartum, are these frontliners, and then affiliated folks like lactation consultants and doulas. So providing information. And so what we are doing with MC3 Perinatal for years now, we are providing know-how, same day phone consults to these providers where they can ask different questions from what are the resources locally, what diagnostically I can't make sense of the symptoms, how do I understand this picture, as well as what are safe medications to prescribe in pregnancy or when the mom is breastfeeding, and providing a lot of the same day phone consult service, as well as having opportunity to telepsychiatric consults, and then providing training, education opportunities to the frontliners and providing resources for these providers. All of this has been around. It's called MC3 Perinatal. It's been around for years. It's free of charge statewide. So next slide. I will come to the MomFacing in a second, but I want to tell you a little bit just kind of the why primary care providers, OBGYNs, because most of the care is actually provided by them in terms of mental health prescribing. Women also feel more comfortable to get their mental health needs met by their OB, by the person who is also taking their physical health into consideration. So a more holistic approach to the medical team also doing the mental health and support. Next slide. This is how providers can enroll. QR code or the web page. Really, it takes 30 seconds to enroll. It's free of charge. It's a lifeline free of charge for providers. Please encourage every provider, every physician, nurse midwife, PA, anybody. We are also supporting non-prescribers, but every prescriber should be part of this model. And we are statewide, but we want to focus region 10. I would hope that every provider in this region is enrolled. Next slide. So this is what I just said. It's the same day psychiatry phone consult, and also the first person who takes those calls, or we have also an online system. Not everybody has to call in. There is no time to call in. You can also put in an online consult request. The first person that picks that up is a behavioral health consultant, a social worker, who, if it's just a resourcing question, can answer immediately the resources in the vicinity, or maybe some apps that we pass on that moms can be given, self-care apps. But if then there is a question regarding medication management, then the psychiatrist gets moved in and responds and calls the PCP back. Next slide. This is for prescribers. If here are prescribers on the call, this is basically what we would ask. We never ask the identifiers of the mom. It's basically de-identified, patient initial. There is a date of birth. So how old is she? How far along is she in the pregnancy? And then we ask insurance, because if we provide a resourcing regarding psychotherapy, who is in the area? We have a database. So how can we best connect to someone who would serve her? And what's the best way to connect with the physician if the physician wants to be called back for a consult? And then we ask, what are the symptoms and what are the questions that you want the physician to answer? Next slide. We are not taking over the care of this patient as a consult service. We are also not an emergency service. So if there's imminent danger or need, of course, we counsel to please take the mom to the nearest emergency room or a psych ER. And we are also just consulting. We are not taking over care and prescribing. Next slide. This is just a flyer for the telepsychiatry consult. So sometimes the the cases are very complex, and even after several phone consults, the physician still might feel, I don't know what's going on, and I would really want the psychiatrist to see the mom kind of with own eyes, and then write up a diagnostic differential. And so then we can also provide telepsychiatry evaluations, which then again report back to the physician, to PCP, what our treatment recommendations would be. Next slide. We have various materials that we also put out. We have webinars monthly. We have recorded training and education sessions. And we have, for instance, these Psychopharm Cards that myself and a colleague wrote out, and we're currently revising with the Michigan Breastfeeding Coalition to kind of make them even more breastfeeding friendly, to put the information out, what medications are safe in pregnancy, in postpartum, and how do you, what's the starting dose? What's your titrations kind of regimen? And what are potential side effects that you need to think of? It's very easy to use, and we're currently building a virtual format for the younger crowd. They like to have it on their smartphone. These are laminated cards that we're currently giving out. Next slide. We also during COVID started so-called provider cafes. These are basically touch-based cafe hours where providers can call in and just kind of chat and be reflective about their patients, about their own stresses. It's, I don't know if folks are familiar with Balint groups, very, you know, kind of as a restorative places of reflection for providers. And these cafes are something like this. So they can be totally confidential, kind of just checking in with someone who understands and can nurture and hold and reflect. Next slide. This is our psychiatry consult team. So I'm the director of this group, and we have every day, we are cross-covering, but we have basically 5 perinatal psychiatrists who are covering the days. And when providers call in, we have special expertise also in infancy and parent-infant psychotherapy, substance use, trauma, and mood disorders. Next slide. Again, the enrollment QR code, please, if you are a provider listening in, please enroll right away or pass this on to your colleagues. Next slide. Now I'm coming to the second level. So with the funding from the Healthy Moms, Healthy Babies initiative through our governor, who really understands the maternal child needs, we have been asked to kind of enhance and expand our programming, and we are doing this in such that we now also give the moms the more kind of putting them in the driver's seat and building a mom-facing offering. And that means that now giving the mom the opportunity to self-screen, so standardized universal screening through an app that electronically collects her own screening results and kind of, you know, ask her various questions confidentially on a tablet or on her own device, iPhone or laptop, and then gives her the opportunity to instantly connect to help, either within the app to get some resourcing, but then also instantly be able to connect to a Tele mental health counselor, a behavioral health consultant who is remote. And that's in select areas, but that's all. We're currently piloting this in the Wayne, Oakland, and Macomb County. And this is called, this mom-facing offering is called HT2, high touch, high tech. So the touch is the kind of instant therapy offering, and the high tech is the electronic screener, the app, and combining that with the MC3 offering with helping the mom to get this intervention if she wants, and connect with the physician of the mom, and if necessary to get medication management started. Next slide. the way how this is going to be is that, again, in the clinics, and so yes, the clinic has to sign on to be part of this. This is something, I see a question here, do you have to go through the doc? Not really, but it has to be the clinic or where the mom is seeking care has to sign up with us and kind of say, yeah, we want this, and be in those three county region, Wayne, Oakland, Macomb. And we are thinking of putting up this QR code. Note, this is not live yet, this code. Currently, we are doing this, piloting it in a different way, but there will be a code that's hanging in the waiting room, and or the app is already uploaded on tablets, as you see here, and she could do this in the waiting room before she sees the doctor, or she has a QR code that is emailed to her before she comes to a virtual initial appointment, and she can do this from home. Next slide. What the mom would then see and will see is basically an interface, and here you have an interface, actually 3 frames of what she would see if she would do this on an iPhone. And there are questions, and then there is this parrot kind of walks her through and is interactive to kind of ease it a little bit. And this is in collaboration with Michigan State, Dr. Steve Ondersma, who developed this app, and we are partnering with him. So it starts off with questions that are really easing and making mom comfortable, and asking her about the pregnancy and how far along she is and how she feels about it, and already asked her, hey, we would like to share your answers with your doctor. And she kind of says, yeah, I'm aware, this will feed back to the doctor. We ask her one more time midway when the questions become more sensitive, are you okay sharing this with your doctor? So next slide. Here you then see the questions then go into screeners, standardized screeners like the EPDS or the PHQ-9 or the GAD-7 or the NIDA substance use screeners for everything, alcohol, substances, illicit drugs, tobacco, and as well as for trauma. We ask for interpersonal violence. And in certain clinics, we pilot also social determinants for health questions. But basically, mom gets these screeners, and then the app calculates if she hits risk on these standard screeners. And if she does, it immediately in the app has this feature where there is some information giving through these videos that are preformed, and it's a kind of a messaging around, for instance, this video is Dr. Jones is an OB and gives now information on tobacco use in pregnancy. What is the impact on the baby? And it is a non-judgmental, just information giving, non-shaming, very motivational interviewing kind of type feedback. Next slide. As the mother gave permission that the doctor can see the result of the screener, this is what the doctor, through a secure portal, would have access to, is the result, the summary statement of that screener. So before the mom even walks into the office, when she did it in the waiting room, by the time she sees the doctor already has a sense of what's going on in the life of this woman in the here and now. You see, this is an example. This woman has depression, anxiety, used alcohol before she got pregnant, is currently using marijuana, has some violence in the past year, and meets criteria for PTSD. So she has quite some going on. And now the doctor can discuss with her what kind of supports she could get. And if they want to start medicine, again, the doctor now could do an MC3 consult and immediately ask, what should I do? Next slide. For the mom, the app ends with this last screen that talks about pregnancy can be stressful, and sometimes it's good to right away have access to someone to talk to. And is that true for you? And so basically asks her, would you like to connect with an expert right here and now, with no waiting, no driving, no cost to you? Again, this is free of charge, all of this. And if she says that sounds good, it connects her immediately to a person a remote BHC from my team who can get in touch. And we asked the mom before she speaks to that BHC, she says, I want to talk right away or an hour from now, or no, please call me at, or what is the best way to connect with me? Texting, call, or video chat. So we give mom a lot of options because we realize that it's the menu that she feels empowered to get what she wants, that might be helpful to her. So next slide. We have piloted this so far, this integration of MC3 and HT2 in the northern regions of Michigan, Alpena, Grand Traverse. And so far, we have had really good uptake. Moms are liking the iPad, they use it, they low refusal to screen. Over 50% of the moms had a positive screen, at least one. You see what the common hits were: tobacco, marijuana, depression, and 2/3 of the moms who were at risk also engaged in intervention. And we have now collected data on 18 women who also went through the Tele mental health counseling. And really, I just reviewed it this morning. Their depression scores dropped, their anxiety scores dropped. We collected also PSI, parenting stress index, dropped when they were postpartum, of those who were postpartum, and just kind of benefited and liked it and liked the menu. So with that, I think I'm at the end of my presentation. And if you have any questions, or if this is something that you would be interested in, if you are in region, which you are, Wayne County, Oakland, Macomb, and you have a clinic where you see pregnant and postpartum women, and you think that this would be of interest to your women, please call us regarding the app. But anybody can already, call and just enroll in the MC3 perinatal provider-facing offering. So with that, I'm at the end. I think my last slide is just my contact, and please email us. Smita is my project coordinator for this project, and my name is Maria Muzik. Thank you so much.
Dr. Muzik, there is one question in the chat for you. If you could take a look and respond real quick, we'd appreciate it.
MC3 is available in statewide, in various regions, Lansing, Saginaw, everywhere. The provider-facing offering is available everywhere. The app, the mom-facing, we are currently piloting in the tri-state area that I just said, Wayne County, Oakland, Macomb. Over time, we would love to roll it out everywhere, but right now, the mom-facing is mainly in these three. And we accept everything because it's free of charge. This is all free. It's no cost to anyone. So we accept for the counseling, nobody needs, we don't bill any insurance. Has this project been publicized through the state's ACOG chapter? So I am reaching out and trying, and please, Teresa, help me. I really would want everyone to know about this. And we have been working with Cheryl Gibson Fountain and with OB, Dr. Jones, and we have a video. And but I don't think that I met with the state ACOG chapter per se. Is there any effort to include pre-pregnancy moms? Well, I would say not yet. Could we discuss? Sure, but right now, no. Has this been any connection with home visiting program? Yes, MIHP. I presented to the MIHP coordinators, and I have MIHP folks who consult with that. They can also sign up for MC3 perinatal and just get information and webinars and resourcing information. You don't have to be a physician to sign up with MC3 perinatal. Anybody can call and ask for the lifeline. So
Thank
thank you again.
you very much. I think we'll move on to our next speaker. Chy'Leetzia Johnson from Starfish.
Hello, everyone. Dr. Muzik is always a hard act to follow. However, there was a question asked in the front that was just going to help me lend to what I want to talk about. Well, let me start. My name is Chy'Leetzia Johnson. I am the Integrated Health Care Manager at Starfish Family Services. And part of our role is that we embed BHCs inside of clinics. Today, I'm going to be discussing two of the programs that are related to mothers and babies. Next slide. So, integrated health with an infant mental health lens. The purpose of our integrated infant mental health lens that we're trying to hold in mind is to make sure that we have support for mothers and families. And I believe there was a question about pre-pregnancy. That's our role inside of the clinics. Our role is to support families before mom becomes pregnant or families become pregnant. And we are looking for those adverse childhood experiences that we heard about earlier when we were talking about the data. Next slide. Some of the key principles of the infant mental health and having that lens as we're inside of the clinic and we're supporting women who are pregnant and those women who are not. And I think it's important to state that we support all of the women that come into any OBGYN clinic where we're stationed. We're there to make sure that we are doing screenings and assessments to help them before they even think about having a baby, but we still have the infant mental health lens. And one of the principles is that a healthy attachment relationship between a child and a parent is so important, but a healthy attachment relationship actually begins before a woman is pregnant. We believe that parental nurturing styles and response to their child or their soon-to-be child is so important, and it can be impacted by the stressors that moms face. And like we talked about earlier, all of the things, postpartum, depression and regular depression and anxiety and those things like that, they impact the woman before she even gives birth. Next slide. The role of the BHC in an OBGYN clinic, as I've stated, is prevention. The biggest part of prevention are doing the screenings. Early intervention is the part where we're supporting the mom while she's pregnant or just giving birth. The intervention is also linking moms to various forms of therapy. While we have here infant mental health therapy, we also connect moms with adult therapy and we connect them with resources to help them feel more comfortable. We are able to do services like brief interventions inside of the clinic, and we provide like psychoeducation and understanding, and also coordination of care, like the holistic health part of it. That's majorly important. It's not just when you give birth, it's not just when you get pregnant, but the holistic care of the mom and the baby. That's what we're there in the clinic to support. Next slide. So I mentioned that that we do screeners for depression, and one of the screeners that we use is PHQ-9. And I'm not sure, I think Dr. Muzik covered it well. It's a screener that our screeners are done more in a relational setting. So currently today, we don't have the high-tech gadgets, but we're hoping to get those, and I'm sure that's coming. But we do it in a relational style, just communicating with mom, timing or woman, because and we're saying moms because that's what I've been saying the whole time. But even if she's not pregnant, we do this with all of the clients that come into clinics. And if there's an initial screening that happened before with the doctor or the MA or someone like that, then we will continue these screenings like at the next visit. Our BHCs make it a point to go into the rooms with the clients with their permission, We go into the rooms with the moms, like typically either before the doctor comes in or after. It really depends on the doctor and the BHC relationship, how things are done, so that it can look very different at each clinic. But we'll do the initial PHQ-9, and then from there we will, do like a depression screener throughout, especially for pregnant moms. We want to make sure that we're paying attention, but we do it more in a relational style where they get to know the BHC that's there embedded inside of the clinic with them. Next slide. The next assessment that we do is the generalized anxiety scale. We do this too because some moms have experienced a great deal of anxiety. Some anxiety that moms face or women face, I think we can all talk about it. Like, all women have some sort of thing that they're concerned about or worried about, but we try to make sure that we're doing these assessments in a way that supports them being able to communicate with us their needs, because as we know, like a pregnant mom, she's going to have some normal anxiety, but we're checking to see if the anxiety is more than typical. And with that infant mental health lens, we're able to see things a little differently, like some things that we know are normal, maybe a doctor would not know is a normal part of having anxiety during pregnancy. And we can help validate some of the experience and feelings that this mom might have while she's in the clinic in a safe environment with a doctor and trusted allies inside of the clinic that she knows, including us being a part of the team. The next slide. So at ACEs, we're already discussed several times, and I think that that's the common thread that's going through all of our presentations. We are doing our best to make sure that we are asking the questions, and we are doing the work that we need to do to make sure that we're communicating with mom and making her make her feel that she is supported no matter what she's going through. But the purpose is to catch the ACEs before she's pregnant. The purpose is to start supporting people, families, before mom gives birth. Some of the questions that we might ask are, what happened to you when you grew up? And we might ask some things like, have anybody around you ever went to jail? These things may not seem like they're a big deal, and we don't always give like an assessment sheet or a flyer. What we do is we try to make sure that we're asking these questions in a way that's non-intrusive, but yet at the same time, getting to the information that's needed in order to best support the families and connect them with the right resources that they need. Next slide. So as I stated, the BHC is embedded inside of the clinic. And this is kind of like the flow of it. There is a screening conducted, as I said, either by the physician or a nurse or even a BHC consultant. And based on what the needs are, the needs that are expressed, the BHC is then able to follow up with the patient and either provide services and make appointments as needed with the patient. It's like they come along to sojourn with moms and walk with them and give them a relational support. If there's no referrals that are needed, then at the time we will then just continue to monitor and continue to be there and provide brief support as needed inside of the clinic. We make sure that when we are doing assessments and screenings to see what mom needs, we're offering her choices of what she would like to have, what's important to her, and giving her information. And I know that it says on here, and we're saying a lot about infant mental health, but we also make sure that we're telling moms about programs like MIHP. We're making sure that we're helping her to make an informed decision based on her needs and not what we want her to do. Because when we're in the clinics, we're not there to fill up our program. We're there to make sure that we're supporting the clinic as well as supporting the moms. One of the things that we do inside of the clinic is make sure that we're having accurate documentation. And we try to make sure that we're doing that in the electronic medical record system that's there, so that Doctors, if we're not able to communicate with the doctor and have discussion about what's going on with this client, because that's not always possible to have a face-to-face, although we would like that, but we know that physicians' times are very busy. We try to make sure that we have accurate documentation inside of the electronic medical record so that the patient's needs can be seen by all that need to know. Next slide. So a potential outcome of having actually a BHC embedded inside of the clinic that has a lens that is geared towards nurturing and support and having a relational communication style and being very reflective and understanding and being able to support the families is that we're hoping to decrease depression and anxiety. And we're making sure that we're thinking about improved birth rate. And we're wanting to reduce abuse and neglect, because there's some things that, because the BHC is embedded and she's able to actually see the mom, create a relationship with this mom or family, because she's able to do that, more information may come out through the relationship that doesn't always come out in other ways. And then our hope is to have decreased ER visits for both mom and baby at the end of the day, so that mom has a connection, somebody that she knows that she can talk to about whatever issues that she's facing, or like simple things. We're not there to tell mom what to do or to tell the clinic what to do, but we are there to be a support and to be a connector to resources for both the clinic as well as moms. Next slide. So this leads me to our other program that's a part of our integrated healthcare team that supports mom, and this is Nurse Family Partnership. Our whole goal with this one is to empower first-time moms and to create futures for themselves and their babies. So that's moms that are up to 28 weeks pregnant. We take moms from all ages, 20 up to 28 weeks pregnant, and we make sure that we're there to support them during the pregnancy. Next slide. Our nurse partnership has 3 goals, and they're on the next slide, so we can just go right there to them. The next slide. The first goal is to improve, can we go back? Okay, well, to improve pregnancy outcomes by helping women improve their health-related behaviors. Our nurses make sure that they're educating and they're providing support, and also making sure that they are helping mom have healthy habits. The best part is that this is one home visiting program that can work for first-time pregnant moms that are up to 28 weeks pregnant. And it is pretty intense level of care, so it is based on what's needed and what the family wants. Next slide. The next one is to improve the economic self-sufficiency for the family, helping moms create their own goals, plans, and making their own decisions, and how that they want to, how they see things. Be sure to add any questions you have. Oh, I see that. I was looking at the chat. And that also includes, so while there's nurses that are going in and providing home visits, they are also helping moms find jobs, and jobs that work with their lifestyle, and also helping them to get their education and other things. But that is one of the goals. Next slide. And of course, to improve child health and development, making sure that we are, so like, say if there's a referral that comes from some other place, our nurses are also providing developmental screenings for the babies, providing developmental for young children, and even helping the mom understand her development based on what age she may be. And also providing depression and anxiety screenings. And they do use the PHQ-9. So if a client actually comes from a clinic, the client has a continuum of care with this particular mom, because we're able to say, here's the initial depression and here is the initial anxiety, and that conversation can go on without what's the word I'm looking for? without there having to be a break in service, but that is based on mom's permission for that to happen. And we try to also make sure that we're providing additional supports for mom too, like, again, connecting them to housing, connecting them to food resources, and connecting them to transportation, even like something that's hard. But again, it's about the relationship and being there to walk alongside in a different way. Next slide. So as I stated before, combining the two programs, the NFP and the IMH program at Starfish, has been helpful, because having that continuum of care, having the BHC inside of the clinic, getting to know this mom, and having a support to pass her to somebody else that's a trusted ally, that's helpful inside of the clinics. Nevertheless, we make it our business to make sure that it is based on what the mom wants and what she needs and what best fits her lifestyle. We are always looking for the collaboration of services and supports, and we are making sure that things are structured in a way that it is relational, but at the same time, it is also addressing the needs, and we're keeping a constant eye on the anxiety and the depression that a mom or may feel. I believe that's it for my slide. Any questions?
I don't see any. Oh, here's a question for you in the chat if you want to take a look at that, Chai. But to answer this other question, a summary of the webinar will be provided. We are recording it, and a recording will be made available, and a slide will also be made available.
Okay.
Shy, I don't know if you want to comment on the note that's in the chat. It talks about our need to do a better job of connecting parents to help me grow, at least in Oakland, in our region, Oakland, Macomb, and Wayne County, and make that connection between Help Me Grow and the primary care providers.
You know, I do believe that one of the things we have provided, I know for our BHCs, is a list of all of the programs. And so we do make sure that we're talking about Help Me Grow. When in the clinics that we're in, we're making sure that we're talking about all of the programs, because what we found is like the more information that moms have, they're able to make a better decision. Now, as far as like other programs and other providers, I really can't speak to, but I totally agree that Help Me Grow should be a priority and brought in with the PCPs. I hope, did that answer the question, or was there another part to it?
I think that was a good comment. You've got a couple of other, we have a shout out from Shonda. She loves, from Christine Walton, who says she loves the fact that you're in their clinic, or a BHC is in their clinic, and they love Shonda.
Yes.
And I guess the last question is, how do your team support patients that show a need for depression care or anxiety, but aren't willing to get help?
So the way that we do it is inside of the clinics, we're able to provide what we call brief intervention strategies. And so if there is space, or if there's support, like we can set up a schedule at different clinics, and each clinic is different for space. That might be an issue, but for the most part, we're able to provide brief interventions. And now, because we're able to use Zoom in a different way, we have we don't use Zoom, forget the name of it because it's off the top of my head right now. But if there's a different program that we're able to use, like video chat with the clients, and we're not charging them for that, but it's a brief support. And what we do with that is hopefully we can encourage them to, by our interactions with them, to actually step out and you get additional support if it's needed for depression and anxiety. And I think we've been pretty successful. In my understanding, like, we're able to connect moms with adult services pretty well.
Thank you very much. Thank you for the presentation as well. Let's move into hear from Karen Schrock, who leads our Project Detroit Versus for Life initiative, and she'll tell you more about what that is doing. You may be on mute, Karen.
No, can you hear me?
Yes, go ahead.
Okay, great. This is a lead-in for the questions we just heard a minute ago about resources. And we're going to very quickly look at some of the resources, but I think the important thing is to make sure that once we've done a brief screening or we've done an assessment, that we are able to move the people towards the care that they need. Next slide, please. So Starfish is an example of a program that is publicly supported. And what we know is that in the Wayne, Oakland, and Macomb County areas, there are 3 community mental health programs. And now you'll notice that they are called integrated health or health networks. And they are funded by the state to provide resources to local community organizations that work on mental health. So if you're in Wayne County, the Detroit Wayne Integrated Health Network, I've put up on the screen both the administrative phone number as well as the 24-hour access number for all of these resources. So Detroit Wayne, then in Oakland County, it's Oakland County Community Health Network. Their crisis line is actually operated by Common Ground, and then Macomb County as well. And the focus of these agencies, again, they're designated by the state of Michigan and responsibilities are laid out in the mental health code, but they fund both mental health and substance use disorder services in their counties. They fund infant mental health services. So the question was raised about what other kinds of agencies are out there. They would be able to tell you, and that would be a question that you could ask on that administrative phone line. They also serve other kinds of specialized needs. So there are programs that focus on women, for example, and programs that focus on people who are homeless. So it's important to be aware of the publicly financed resources in your area. And someone used the word empowerment. That's critical because you want to make sure that the women that you're serving and their families have the chance, the opportunity to be involved in the selection of that provider. It is not our job to select providers any more than it would be our job to say, go to this OB-GYN. Next slide, please. In addition to the publicly supported programs, I wanted to mention particularly the importance of advocacy and educational groups. Many of the people who are involved in the mental health system as advocates actually have family members who are involved in the mental health system as consumers. I wanted to particularly call out a few. The National Alliance on Mental Illness, you'll hear it referred to as NAMI, and that's the Michigan chapter. I put their information on there that you can contact them. They have an annual conference coming up in a couple of months. They also do an annual NAMI walks to raise money for the organization. And in Southeast Michigan, that will be this August 28th at Belle Isle. In addition to that, we have the Michigan Association for Infant Mental Health, and they provide a lot of information on the kinds of resources that are available. I put the Reflective Practice Symposium that's coming up at the end of September here for your information. And then lastly, I wanted to mention that we are very fortunate in this state to have had people focusing on infant mental health for decades. And I'm saying at least 4 that I know of. Within the department's Behavioral Health and Developmental Disabilities Bureau, there are infant mental health specialists. And when I looked the other day, there was still the guide on social and emotional development in young children, and that can be downloaded. Sometimes parents just don't know what the markers are, what their child should be doing at a certain age. And our State Department has actually published a document that any of us can download that will help you with that. So the important thing is to be aware generally that there are a lot of resources out there. Sometimes what is a problem is that people aren't aware, so they can't use the tools. They can't access the resources and they can't get the help. So I'll leave it at that, Alethea, and turn it back over to you.
Okay, thank you. I think that was an excellent wrap up. We're a minute or so over time, but we still pose the same questions that we started with. We hope the information that was shared today was useful. I think Karen sharing the resources that are available was a key component to the other 2 speakers that we heard, who were both excellent, but certainly making sure that women have the option to choose what they need, and then knowing about the resources that are available to help meet those needs are key. So thank you for attending. We had a group of more than 50 participants today, and so we'll share some important dates with you right now. As I mentioned earlier, we have quarterly meetings as part of SimQuick, and the next one is coming up June 22nd. We also do an annual meeting that highlights the most recent infant and maternal health data that comes from our state's vital records area, and that is scheduled for June 17th. We've got the links for all of this so that you can feel free to join. I neglected to mention that I do have 2 partners, Vern Davis Anthony and Dr. Iris Taylor, that also work with me, and Lisa is leading SimQuick. So we hope you can join us. And then I'll just wrap up by saying the state's maternal infant health summit is coming up June 28th and 29th. And you can Google that and get a link if you're interested in joining. Thank you again. We will be sharing the recording of this session along with the slides from all the speakers for your reference. Have a good afternoon. Oh yeah, let me also mention to please complete the evaluation. That helps us know if we're on track with what we're presenting and the way we're presenting it, so that we can schedule future tools for the field sessions like this that meet the needs of our community. So I will say thank you again for attending. Have a good afternoon.